Oh, okay, we have some more people. I was gonna say the Cowboys winning, so most people should have already gotten, turned away from that game. All right. Any questions before we start? Oh, here we go. Dead silence again.
Yes, what will be in the exam?
What's going to be on the exam? All the stuff we've covered, and then all the stuff Miss Rajni covered.
Give us some questions that will come in the exam.
Oh, okay. I'll give you some questions. It's going to ask you about hyperkalemia, hypokalemia, hyponatremia, hypernatremia. Yeah, all your electrolytes. So keep studying. Know the difference between DI and SIADH. All right. Somebody has a football game going or TV or something in the background. So if we can go ahead and mute that component, then that will work. Perfect. All right. So I wanted to go back to the electrolytes. We didn't cover the hypophosphatemia and the hyperphosphatemia. I think those are the last two. So remember that calcium, mag, and potassium are all a part of the cardiac system. And they're all going to have electrolyte, and they're all going to have EKG changes. So what I want to do is kind of show you, let's share my screen just a sec. All right, so everyone should be looking at the electrolyte imbalances here. Can you guys see that? Yay, nay, still thinking about it?
Yeah, we can see it, but let's...
Can you not see it?
I need to take a picture of it. Okay. Okay.
Well, it's going to be on the Zoom session and it's being recorded, so you'll still have access to it. Mm-hmm. So you don't necessarily need to stress your gut over it one way or the other. But overall, just the question came up about all the different ECG changes that happen with your electrolyte imbalances. So they're all kind of just right here in one little section, so that way you can have them all together, so to speak. Okay? And you actually already have access to this component. It's also in your Saunders, in your page bursts for your Elsevier resources. So let me find that real quick. And I'll share that screen. Okay. Well, this is interesting. Hold on. So I had it up earlier. So when you go to page bursts, I'm gonna go back in just a second. Just move this down. Make it bigger. So in your Saunders book, if you go to the fluid and electrolytes page or section, then you can actually see they have the tables. Okay, somebody has me on their microphone. To try to mute that, please. So let's go back to page 80 if I remember correctly. So that's the fluid and electrolytes page. And so it gives you all of the different electrolyte imbalances, your input, your output. And as you continue to scroll through, it looks at your volume deficits and excesses. And I'm just kind of scrolling down to where I wanted to be. But it talks about all of your different electrolytes, your kalemias, calcemias, natremias, and they're actually comparing the two side by side. So if you kind of want a snippet of what what's going on, this would be a good spot to, I didn't mean to do that. This will be a good spot to look at it. All about the muscle twitching, the paresthesias, the numbness and tingling, profound weakness, and it goes through each one of the electrolytes. So this is kind of a snapshot, low down dirty, if you want to call it that, view of all the electrolyte imbalances. And then here's the two natremias compared together. And then at the end or towards the end of it, it will have or give that chart, because that's where I pilfered it from. If you're not sure on the Chavstetsky sign and the Trousseau sign, it explains that there and what you would expect to see. So here's the hyper and hypokalemia. So have you all been to your Saunders book at all, just to see, kind of help you solidify some of these electrolyte imbalances?
Yes.
Is that a yes or no? I heard something.
Yeah.
Okay. So although I'm kind of zipping through, if you haven't been to the resource page, I'm just going to go back to the home page. It's this book that I'm actually in, the Saunders Comprehensive Review, NCLEX RN Examination by Silvestri. So you guys should be going through there and at least doing some NCLEX questions, about 30 of them a week. And you would find some of you have this this edition, the green book, and some of you have the newer edition, which is this red book here. So the 4th edition is very similar to the 5th edition. So that's where you should be doing your actual NCLEX questions. But you can use Saunders, whether you have the 7th edition or this 6th edition, which is here, which is the same thing. It's just edition 6, but it does the same thing. So it gives you kind of a snapshot of, of what the different electrolyte imbalances are. So you're kind of hitting the high points of what's going on. Okay. All right. So with that being said, let's look a little bit at your hyperphosphatemia, which is basically high phosphorus in the blood and usually greater than 4.5. So how does phosphorus work in comparison to some of your other electrolytes? And what is it very similar to or kind of share issues with?
Calcium.
Calcium. So they
when
don't.
Phosphorus goes up, calcium comes down, and vice versa.
Correct. So where are they coming from? Which hormone or which gland?
Parathyroid.
The parathyroid gland. So it's all about the secretion of the parathyroid hormone, whether you have hyper or hyposecretion. Vitamin D also plays a role because it looks at how phosphorus is absorbed, same thing like calcium. Most people will take calcium with vitamin D because of vitamin D helps to increase the absorption of your calcium. But when we're talking about phosphorus, we're looking more at what system does more of your phosphorus absorption in your body.
Your intestines?
That'd be the GI system. So the GI system is where a lot of your phosphorus absorption will take place. So if you have, if you're taking specific antacids, then that may affect the absorption of phosphorus, which will then affect your calcium and some other electrolytes. So the kidneys, what's the concern with phosphorus in the kidneys? Does the kidneys like phosphorus?
No.
Okay, so let's just kind of back up. How does phosphorus work? So basically, we find it in our teeth and our bones. So if we have an imbalance, we could potentially have fractures. We could potentially end up with bruising or ecchymosis very easily. The bruising would be due to your platelet aggregation has now been altered. In the extracellular fluid, it supports a lot of the metabolic functions like your vitamin B use, your acid-base balance, your bone formation, nerve and muscle activity, cell division. So there's a lot of different things that phosphorus plays a role in, as well as the metabolism of carbohydrates and proteins. And we're going to talk about the issue with end-stage renal disease patients, proteins, foods that are high in proteins, and, you know, taking phosphorus tablets or supplements. So usually if these patients have, you know, any type of kidney dysfunction, and failure, the kidneys are not working, which means they're going to retain a lot of the phosphorus because the kidneys are not working, it can't excrete it. And in certain situations, it's viewed as being a toxin, so that can be that will be another issue. So at the renal tubular area, then we have the reabsorption of the phosphate, which is kind of inversely regulated by the calcium levels. So as the phosphorus levels increase, it's going to cause a decrease in your calcium, which we already talked about. The imbalances the two share. So an imbalance that causes hyper or hypophosphatemia is kind of what we're looking at. An excess of your phosphorus load would, from the GI absorption, these are problems that you can see, or the reason why we have hyperphosphatemia. So we have an excess of phosphorus load from the GI absorption. We could have administration of phosphorus material or medication. We can have cellular release, then the tissue's ability to uptake it, or the kidney's ability to excrete it. So a big concern that we'll see, or some of the causes of hyperphosphatemia or high phos levels, would be overuse of vitamin D. We would also have the hypoparathyroidism, which is decreased secretions of your parathyroid hormone. So the kidneys, keep too much of your phosphorus in the body. Another cause of hyperphos would be kidney failure, so the body can't excrete it. If you use like a Fleet's enema, what does Fleet's enema have in it?
Phosphorus.
Has a lot of phosphorus. So any laxative that contains phosphorus, if they're using it repeatedly, then the person's going to have difficulty excreting the phosphorus levels. There's something called tumor lysis syndrome, and this is usually for patients that are receiving chemo. So chemo actually kills all your cells, not just the tumor cells, but it also kills your good cells. And when that happens, then your electrolytes that's inside the cells, like your phosphorus, your sodium, and your potassium, they now get dumped out into the blood. Now you end up with the increased phosphorus in the blood. Rhabdomyolysis, what's significant about that, or rhabdomyolysis? What is rhabdomyolysis? What does that mean?
Isn't that like where your muscles basically lyse, or they're destroyed, so whatever protein in them?
Right. So what ends up happening is there's a rapid destruction of the muscles, and so that causes breakdown or necrosis. And the dead muscle tissues is going to release a myoglobin, and the myoglobin in the blood becomes very toxic to the kidneys. So it causes the kidneys to shut down or potentially go into renal failure. Therefore, that decreases the kidney's ability to excrete phosphorus. So it's kind of a circle loop. One particular situation causes another. How do you get rhabdomyolysis? It could be from injury. So there's a variety of reasons of why it occurs. But if you have someone with myoglobin, or their myoglobin levels increase, that means there's some type of tissue destruction or tissue necrosis somewhere in the body, even if that meant the heart. So you have to be mindful of that too. What about what type of acid-base imbalance would somebody be in if they had hyperphosphatemia? Alkalosis or acidosis? He goes, they would actually be an acidosis. It could be metabolic or respiratory, depending on the patient's situation. So speaking about the end-stage renal disease patients, a lot of times they're going to be on a medication called Foslo, and it's a calcium acetate medicine. And it helps the patients that have end-stage renal disease keep their potassium levels low. So that's
medication?
Phoslo, Phoslo.
Okay.
So that it's a calcium acetate, and it helps to decrease phosphorus levels. So that it's a phosphate binding drug. So the patient will take it with their meals, or they'll take it subsequently, right after eating a meal. And that's going to be excreted through the stools or through the stool system. So if you have an end-stage renal disease, some of the patient education you would teach them is to eat meat, eat their meals that don't, or not to eat foods rich in phosphorus. That's what I'm trying to get around to saying. Because if they're already eating a high phosphorus meal, then, they could be at risk for hanging on to it since the kidneys are not working as well. Okay. So we have Fleet's enema that can cause hyperphosphatemia. We have laxatives that contain phosphorus or phosphate that can do it. Oral phosphorus supplements and vitamin D supplements. So those are all issues that can lead to hyperphosphatemia.
I don't know, but if I could just ask, because I don't understand this phosphorus and calcium. Almost the same things give you phosphorus and they give you calcium. They are both stored in the bone, but how are they so unalike?
Okay, so remember, when your phosphorus is high, then usually your calcium would be what?
Low.
Okay, so if we gave them a calcium supplement, would we not now balance it? Because as we're increasing calcium, we would be expecting our phosphorus levels to increase or decrease?
Decrease.
They should decrease. So it's like a check and balance system. Now, if you have a patient, outside of just having hyperphosphatemia or hypercalcemia, then that you would have to hold that condition in its own right. Does that make sense? So you would expect for that levels to be opposite, but what if you had a patient that had a hyponatremia and for some reason they had a high, a high level of, calcium? It may not necessarily mean their phosphorus level will be low because their problem is really the hyponatremia. Does that make sense? And that's why, as try not to group these, because you can have these independent of disease conditions. They don't necessarily run hand in hand. But if your patient is just having a straight, legit, just a calcemia problem, then you can look at the phosphorus. Does that make sense? Okay. So what I would say to do is, if you're still confused, do you have Giddens' book?
No, I'm not. I was just wondering about it. I know what to memorize for an exam.
But not so much memorize, just understand how they work. We're not memorizing. We're trying to understand how the parathyroid hormone works and, what role does the calcium play because of it. So I remember doing the kind of the pathophysiology behind the calcium and, and its location. So go back to that component, because it is, when you're doing all the hypers and the hypos, it is easy to get them confused. And that's why I tried to do it in smaller pieces than just doing all of them in one fell swoop. So that's why I've done some of them on the Zoom session. So that way it's broken up and you can kind of digest it a little bit easier. Okay. All right. So the different signs and symptoms that we would be looking for, definitely if it's hyperphosphatemia, then we should expect to have hypocalcemia, right? They can potentially have bone fractures. What would you expect their mental status to be? Would it be good? Would it be confusion? They have seizures? What?
Lethargic.
So lethargic is
confusion.
They're going to be confused. So if you go back to the low calcium, if I remember correctly, if you go back to the low calcium, I'm just double checking, making sure that I'm saying the right one, then you will see all of the different signs and symptoms that we talked about, the confusion, anorexia, muscle cramps and spasms, the tetany, the seizures that they can potentially have, hyperreflexive or the hyperactive reflexes of the deep tendon, so the deep tendon reflexes, the Trousseau sign that we talked about when we did it for hypocalcemia. You guys remember that? Have you been looking at it? So all of those same signs and symptoms would be applicable here for hyperphosphatemia. So I talked about the confusion, the hyperactive reflexes. They had the arrhythmias, which I just showed you a screenshot of that. Muscle spasms in the calves and feet. They can have seizures. And then the Trousseau sign, which is, the latent tetany, the Shavatsky sign. We talked about those. So they would have the exact same signs and symptoms. Do you remember what the Shavatsky sign was?
Trotsky, I'm not Trotsky is the, I don't, okay, yeah, where you hit and then you bend to it. Yeah.
Right, so you hit the masseter muscle at the angle of the jaw, and based on if they have hyperphosphatemia, which would be hypocalcemia, then it would actually cause twitching of what two areas of the face?
Nose and mouth.
The nose and mouth would start to twitch. And if that was on the Trousseau sign, then we would pump up the blood pressure cuff, let it sit for 3 minutes. And in 3 minutes, if they have hypocalcemia, which would be if they had hyperphosphatemia, then we would actually see their hand kind of start to contour this way on its own. So the patient wouldn't do it unless it was actually doing it on its own. And that's the one thing about Saunders, it actually gives a picture of what the hand motion would be. So that's why I took you to that Saunders book, The Comprehensive Review, because it did have a picture of that. And it did talk about those two signs. So if we have the hyperphosphatemia, then we would expect our calcium to be less than 8.9, right? And then we want to check our magnesium level, because our magnesium, our phosphorus, and our potassium all play a role with your heart conduction. So that's kind of, the reason why we're focusing on those electrolytes and making sure we don't have somebody that's going into a lethal rhythm. So outside of lab work, are there any other studies or lab studies or diagnostic tools that we can do besides lab work? I put it up on the board in class on Tuesday. It would be a 12-lead ECG. So we need to get an electrocardiogram so we can see if they do have the prolonged QT waves, because that's what we'd be expecting, correct? For hyperphosphatemia, which would basically be hypocalcemia. So they would have a prolonged ST and a prolonged QT segment. Okay. The only other thing we would do as far as a diagnostic study would be an X-ray. So if we're worried about fractured bones or anything like that, or if there's been any changes in the bone, then that would be seen on X-ray. So we're going to treat the underlying cause. If the patient's levels are extremely high, then they're going to have to go and be dialyzed. Okay, so we need to make sure of that. Tell them to stop any drugs, the fleets enema, laxatives that contain phosphorus. They may end up doing a gastric lavage if it's, if they have too much phosphorus on board, and then putting them on prophylaxis for clots. So name some foods that would be rich in phosphorus. Didn't hear that.
And then avocados and like green leafy vegetables.
Well, not so much the avocados and green leaves, but all of your meats, your fishes, your chicken, your beef, your pork, your organ meat, like liver, that would be rich in phosphorus. Fish would be rich in phosphorus. Peanut butter, nuts, dark chocolates, chocolate, not necessarily dark chocolate, but chocolate. Whole grains, those would be foods that are rich in phosphorus. So if we have hyperphosphatemia, what are we going to tell our patients to do?
Limit those foods.
They should eliminate those foods. Okay. So we'll give them Foslo, give them IV fluids for hydration, give them the Foslo to help the GI system absorb the phosphorus levels, so that way it can be excreted out in the stool. And pretty much that should be it. And Foslo is a phosphate binder, but it's a calcium-based phosphate binder, like calcium carbonate or calcium acetate. So any questions about that? So we tell them to avoid foods that are high in phosphorus. So do we want to check bowel sounds with that individual and if so, why?
Because if they're taking Foslo, we want to make sure they're able to pass stool efficiently. And if they're not having bowel sounds or no movement, then you're just creating another problem.
Correct. Because now if they can't, then it's just going to bind there, and they're going to have now the phosphorus levels are going to be higher. So we would be putting them at further risk for to have a higher level of hyperphosphatemia, and they may have to now become dialyzed. So I don't think we really want to do that, right? Because that wouldn't make any sense. So anything else on hyperphosphatemia? Somebody had a small blowout there. Okay, so let's look at hypophosphatemia. So this is low phosphorus levels. Okay. Again, we know that if it's a decrease in phosphate levels, then our teeth and our bones are going to be affected. So we would expect to have some type of bone fractures. Again, it does work with metabolic functions, and including the use of the B vitamins and cell activity, muscle activity. So we may expect to have some profound, weaknesses in areas. So the parathyroid hormone is also a part of this process. So do we have hyper or hyposecretion of the parathyroid hormone?
Hyper.
Okay. So now we have too much phosphorus levels, too much parathyroid hormone, not phosphorus levels, but we have too much secretion, and it totally inhibits the reabsorption of the phosphorus from the kidneys. So it's basically causing the kidneys to waste the phosphorus in the urine. So it's just basically going to pee it out. So where's another condition where we see polyuria?
Diabetes.
So DKA, diabetes, hyperglycemia, glycosuria, that's where the glucose spills over into the urine, and that usually happens when the blood sugar level is greater than or equal to 180 milligrams per deciliter. So if your patient's blood sugar is over 180 or 180 and above, then we may also be wasting as well phosphorus, as well as our glucose. Does that make sense? No, yes, maybe, thinking about it. Okay. So the kidneys are basically just dumping the phosphorus is what's happening there. Chronic use of aluminum hydroxide antacids or magnesium-based antacids. This can also alter how the GI system absorbs the phosphorus, and it can actually cause a malabsorption to occur. Okay. Hyperparathyroidism results in does that result in hyper or hypocalcemia? Hypercalcemia. So because of that, then that's the reason why we see the hypophosphatemia. Does that make sense?
Yes.
Okay. All right. So other causes would be taking parenteral nutrition solutions that don't have enough phosphate content in it. Vitamin D deficiency, where before we had a concern with the overuse of vitamin D, right? So now we would have a concern with vitamin D deficiency. Then we have it is osteomalacia, which is basically softening of the bones, but it's an oncogenic process where the kidneys is going to waste the phosphorus. So therefore the levels of phosphorus are decreased and the bones begin to soften and cause fractures. And that can be related to either a malignancy or a tumor of some sort. Burns, remember there's a lot of fluid shifting, so actually the potassium is going to shift out of the blood and into the cells, leaving what's in the blood already to, if it's already low, it's going to be lower. And then having an increase in calcium, decrease in mag, and a decrease in potassium can also lead to hypophosphatemia. So high calcium, because remember they're opposites, a low mag, and then a low potassium level, so a low K level, all of those can, or any of those can actually cause your phosphorus level to decrease. What acid-base imbalance would you expect a hypophosphatemia person to be in?
Alkalosis.
It'd be alkalosis. They'll have respiratory alkalosis. Okay. And the reason being is because the muscles will be weak, and because of those weak muscles, they're going to have breathing problems, so that they're going to end up retaining, they're going to end up blowing off CO2 like in hyperventilation. What about your alcoholic people? Do we have a concern about them, or are we GTG with them, good to go? Do alcoholics drink? Do they drink a lot? That's why they're alcoholics. Do they eat a lot? Do your alcoholic people eat?
No.
Nope. So yeah, they do more drinking than eating. So for these folks, the body's ability to absorb phosphorus is diminished. So usually because of their malnourished state and their body's inability to absorb the phosphorus is the reason why they have hypophosphatemia, which is another reason, along with other electrolytes, but it's another reason why we give them that banana bag. So with all their electrolytes and, things that they need that they're not getting, their thiamine, because of their... Oh, somebody's having a good time out there. So if you want to know how well like your calcium carbonate or any of your, and this is going back to the hyperphosphatemia, if you want to know how well those medicines are working, what could you do? What would you need to check? How do you know that it's being effective? If they're given one of those like calcium acetates or something like that to help decrease the phosphorus levels, what could you check to see how that, what's going on? So if you're given the calcium to help decrease your phosphorus levels, when the best thing to do would be to check the phosphorus levels or the phosphate levels?
Yeah.
Okay. So if that's your goal, if you want to see how it's working, then that's what we would do to check it. So what signs and symptoms would you expect to have? I think I missed one more cause. I think it has to do with nutrition. From the nutritional standpoint, it is one more cause of, or things that you want to look for. Something called syndrome of refeeding. So patients, so this goes back to your patient on TPN, so your parenteral nutrition, those that are malnourished or those that are starving. So those particular patients, their body hits survival mode. So when you don't eat something, your body literally hits survival mode. And then the food, when it's reintroduced back into the body system, it'll basically put the body at shock. So now your insulin just starts to release a bunch of glucose. Now you have hyperglycemia. And with that hypoglycemia, it tries to synthesize, that process, and the body then starts to release phosphorus, mag, potassium, which are already depleted. So if it's already depleted in the body, then are we going to have higher or lower levels of those electrolytes? It's going to be lower. So now we have further low levels of phosphorus. So that's another reason why you would see someone with hypophosphatemia if they're, starving, homeless, malnourished, those types of individuals. Someone that's on TPN. Okay, so signs and symptoms, as I started talking about before. What kinds of signs and symptoms would we expect to see? I talked about the breathing problem secondary to muscle weakness. The rhabdomyolysis, so that's, this is where we have the necrosis of the muscle. What kind of urine, if you're looking at someone having rhabdomyolysis, what would be the signs and symptoms you would expect to see? I don't know if that was a sneeze or a cough, but if it was a sneeze, bless you. So their muscles would be weak, they'd have muscle pain, their reflexes would be diminished, but their urine would be tea colored. And that's due to that myoglobin that's being released in the blood as well. So decreased phosphorus.
What?
The urine is tea colored, like very concentrated. So they have muscle weakness, pain, decreased reflexes, tea-colored urine. So although tea-colored urine could be seen in other, like in dehydration, correct? So
If the muscles are breaking, being lysine, usually it's creatinine that usually does that increase as well? Creatinine and
well, the creatinine has to do with the kidney function. So if you have a high BUN and if you have a high creatinine level, then they're not going to be able to clear the phosphorus. Because the kidneys wouldn't be functioning correctly, right? So it'd be difficult for them. That's why we talked about the end-stage renal people earlier. So that's why they end up with a high phos versus a low phos. Okay. So we talked about osteomyalgia or osteomalacia with the bone fractures, bone deformities. From the heart standpoint, they have a decreased cardiac output. It's going to suppress the immune system. So we have the decrease in platelets. The patient's going to have bleeding or ecchymosis. So we need to watch for those signs and symptoms. Bruising, confusion, seizures, irritable. Those are all mental status changes that they will have. So everything's just kind of getting all tired and weak and broken down. Like their muscles, they're going to be extremely tired. The patient's going to be extremely weak. And so they're, this is our phosphorus levels that are going to be less than 2.5. As we are trying to correct some, if we're trying to correct hyperphosphatemia, we can potentially throw the patient in hypophosphatemia, right? Okay. So how would we treat a person with hypophosphatemia?
Foods high in phosphate.
Say that again, I didn't hear that.
Increase the calcium level. Okay.
Foods high in phosphate.
So basically tell them to eat foods high in phosphate. So all the foods we talked about with hypophosphatemia with hyperphosphatemia to restrict the ones we would tell them now to take with hypophosphatemia. So they would need to take their fish, their organ meats, their beef, pork, chicken, whole grains. So all of those that we talked about when we looked at hyperphosphatemia, and we were going to tell them to restrict the diet. This is now we're going to tell them we need to beef up your diet in that area. Patient safety, because we're going to be concerned about broken bones and weakness, so we don't want them to, fall out of bed. So we want to keep the bed down. We want to keep the side rails, appropriate. Put the call light within reach. If they're on TPN, just understand that risk for rhabdomyolysis or myelitis. So we're going to monitor for that. So we'll be looking for that tea-colored urine, right, that we just finished talking about. We'd also be looking for muscle weakness and pain, the deep tendon reflexes being diminished. Then we're going to give them some type of oral phosphate medication with vitamin D to help increase the absorption of phosphorus. If the phosphorus is less than 1, then we need to check their renal status, their BUN and creatinine, to see if, because if it's high, then it won't clear. Not sure there was a buzzing there. Monitor calcium levels to make sure that they don't go down when we're treating them. So if they have increased phos, then we want to monitor that. Because if they have hyperphosphatemia and we're trying to treat that, we may actually put them on the opposite side or make them too low. So any questions about hyperphos and hypophosphatemia? You still thinking about it? Maybe, no? Somebody's having a good time outside. I don't know who that is, but those kids are having a blast. All right, I think the last thing we're going to talk about is syndrome of inappropriate antidiuretic hormone. So we've covered all the electrolytes, and so eliminating all the electrolytes, well, we've covered all of those. And so the only thing we did not talk about was SIADH, but we did talk about GI. So remember, this starts back with the pituitary gland. And so we have excessive release of the antidiuretic hormone, which actually causes a water excess in the body. So now if we have extra water in the body, what's happening to our sodium?
Because the ratio of the water to the sodium becomes hyponatremia.
Correct. So now we're going to have hyponatremia because the sodium is going to be basically diluted inside the body. How to treat it is treat the underlying cause. That's the best way to treat syndrome of inappropriate antidiuretic hormone. So remember, antidiuretic hormone is to prevent you from peeing a lot, correct? So now we have excessive secretion of the antidiuretic hormone. So would we have polyuria or oliguria?
Oliguria.
You'd have oliguria, okay? So that means scanty urinary output is what oliguria means. And anuria means no urinary output, okay? So from the excessive water absorption from the distal convoluted tubules and the collecting ducts, we're gonna end up with a hyponatremia for this individual and an increase in their extracellular fluid volume. So internally, they're going to have more water. What's the other concern with when that happens? So when we have excessive secretion, we have an increased renal tubule permeability, which means we're going to have an increase in our water retention and expanded extracellular volume. So if we have, that can lead to reduced plasma osmolarity, and we can end up with an intracellular shift, and the patient can end up with cerebral edema. So that's another issue that we need to be on high alert for. So what causes syndrome of inappropriate antidiuretic hormone?
Pituitary problems.
So you can have
cancers,
cancers, pituitary problems. What else?
Addison's disease, COPD.
Okay. Myocardial infarction, atelectasis. So remember mixed edema? When we talked about that way in the beginning of the semester, that was endocrine disease concerned with thyroid, right? So that can also
hypothyroid.
Right. So that can also cause that to happen. Mechanical ventilation can also be a cause. Somebody with that's taken ecstasy can also be a cause for having syndrome of inappropriate antidiuretic hormone. Anything that affects the central nervous system, that can cause a patient to have syndrome of inappropriate antidiuretic hormone. So, head injury, anorexia, weight gain, those could be, if they start gaining weight and they, that will be that intracellular weight as fluids are shifting. So what would you expect their mental status to be if they're hyponatremic?
You'd be confused.
So they're going to be confused. Okay, lethargic, they may have headaches, they may have an increased thirst, right? Seizures, tachycardia, sluggish deep tendon reflexes, weak muscles. Cheyne-Stokes respirations is it's an irregular breathing pattern for which the rate and depth increases and then decreases with a period of apnea. So as the rate increases, so does the depth. So it's almost like an accordion. It's almost like an accordion type breathing. So it starts off really slow, gets bigger, 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 bigger. Then it gets slower and more shallow, shallow, shallow to the point that the patient becomes apneic, and then it restarts up over again. So it's like an accordion, and it's like an accordion effect that they will have when they're breathing. So that's usually caused by head injuries. So if you have a patient that you would be, suspecting that may have diabetes insipidus, then, not diabetes insipidus, but syndrome of inappropriate antidiuretic hormone, then they would probably, be confused, right? Outside of knowing what the cause of it is. And then hyponatremia would be your hallmark sign related to that. Now, can you have hyponatremia without having syndrome of inappropriate antidiuretic hormone?
Yes.
Yes.
Yes, you can. So I just want to make sure that that's clear. Okay. So what if the serum sodium level is, 115? Should we be concerned?
Yes.
Yes, very.
Absolutely. If the serum sodium level is less than 120, then, we need to start looking at the patient for, possible seizures, comatose, and we need to do quick, how will we treat that?
You'd restrict the fluids.
Okay. What would be our correction? Go ahead. Sorry about that. Somebody else was trying to say something at the same time, so go ahead.
We'd make sure the head of the bed is flat or less than 10 degrees.
Okay. So how are we going to get the sodium levels up? So if the sodium level is a problem, how are we going to correct it?
The IV fluids of 3% saline IV fluids.
Correct. We're going to give them that 3% normal saline. That would be what they would need at this point to get the sodium level up. Just trying to give them something PO, that's not going to work. That's going to take too long to work, right? Mm-hmm. Okay. So Other complications, as I said, we want to look out for would be cerebral edema and water intoxication. So we don't want to minimize those. And the patient can actually die from having that dilutional hyponatremia. So head injury, as I said before, is a risk. They can have tachycardia. That can be another sign or symptom that you see. Their serum, so this is their blood, osmolality is going to be less than 280. Their urine, their sodium levels in the urine is going to be more than 20 millimoles without diuretics. So this is if they're not on any diuretics. And their serum osmolality is going to be greater than or equal to 100. So how are we going to fix, what kind of medications are we going to give the patient?
Is this where you would give them declamycin?
Yes. So you can give them declamycin. That's one medicine that you could give them. Or Carbolith for long-term treatment. We might give them a loop diuretic with, sodium and potassium chloride for fluid overload. But we want to make sure we monitor patients that already have a history of heart failure or that may not respond to the treatment. We've already talked about 3% sodium or 3% sodium chloride or normal saline. We talked about that, especially in our patients that have a sodium level less than 120. Okay. If it's cancer, the only thing we can do is treat the underlying cause of the cancer. There's not a whole lot we can do with that one.
What'd you say?
I said if the patient has cancer, then there's not a whole lot we can do with that person that has cancer. Try to treat it with chemotherapy or radiation, depending on what it is that they have. We're going to, since we know that they have volume overload, we're going to actually restrict their fluid intake. So we're not going to give them a whole lot of fluids to drink or anything like that. We're going to restrict them between 500 and 1,500 milliliters per day. So they should have a high salt, high protein diet, or do urea supplements to enhance their water secretion. And so when you say with people like high salt, yes, they're already volume overloaded internally. So we just need to now kind of push that out so the patient can pee it out, right? Because we're talking about someone that already has hyponatremia. So we need to give them some type of salt or give them a high salt diet, but also a high protein diet to go along with that. So if you have a patient, how do you check whether or not your elderly patients, where would you check to see where's the best place to check for an adult, not even just elderly, to see if they have, if you're checking their skin. So where would be a good place to check their skin to see if they have any tenting?
Their ankles.
So that again.
Their clavicles.
So the question was, where would be the most or the best places to check, or what places could you check for an older adult or for an adult? It's actually more for an older adult because they have saggy skin. So where would be the best place to check for an older adult to see if they have hydration? If you're going
to mouth.
Okay, you can look at the mouth, but if we're going to speak more specifically on the skin, because their skin is saggy. So where would be a good...
Their clavicle?
So chest would be a good area. Like the sternum, not necessarily clavicle, but sternum. Because it's kind of hard to get skin there if I'm getting it at my clavicle. But I can grab more at the sternal level. Where else? You could do forehead and belly. So we can't rely on their hand because they've lost a lot of elasticity. So we can't rely on their hand for that. Okay. So what two electrolyte imbalances are associated with alcoholism? We just talked about one. We just talked about one. So
Phosphate,
hyper or hypo?
hypo,
Correct. And what else? Somebody said the other one.
Magnesium.
Hyper or hypo?
Hyper. Hypo. Not a 50-50 shot.
I know it's a 50-50 chance. But yeah, hypophosphatemia and hypomagnesemia are both associated with alcoholism. So they're going to, for patients that are alcoholics, they're going to have low mag and low phos levels.
would it be high mag or low mag?
Low.
Low.
So how would your DI patients present? Your diabetes insipidus. What signs and symptoms do you see with them?
Weight loss, because they're losing a lot of fluid.
Okay, so let's start with signs and symptoms first.
Polyuria, dyspnea.
What about their mental status?
Would they be confused and lethargic?
Confused and lethargic, yep. And some of them not able to drink water. But we did talk about the high urinary output, the polyuria. What about their specific gravity? Would it be high or low? 50-50 chance on this one.
Low.
It's going to be low.
Less than 1.
Correct. We talked about that in class already. So foods that are not rich in phosphorus will be your green leafy vegetables and your high fat foods and fruit juices. Those are not high in phosphate. So just FYI, I know someone talked about that earlier, but those are not high in phosphate. But your dairy products are, they're high in phosphate, dairy products and milk.
Like I said, it's whatever gives you calcium, gives you phosphorus. That's the funny thing.
Correct.
Like vitamin D. No, it's just funny. My word.
All right. So sorry about that. My phone was ringing. I had to mute my phone or mute my button. Okay, let's see. Do you remember, why do we give patients, what kind of patients, and we talked about this, this was probably the first, or last week, not this week, but not this past Tuesday, the Tuesday before, when we did chronic renal failure and end-stage renal disease. And we talked about them receiving Epigen. What's Epigen? Or Epigen.
Erythropoietin?
Is it what now?
Erythropoietin, is that what you said?
Yes, it's Epotin or Procrit?
It's red blood cells.
Okay.
It's to help produce red blood cells.
So it does help produce red blood cells. So the one caveat you have to remember about when you're taking that med, how long does it take for it to work?
A couple weeks.
It's going to take about 4 weeks for it to work. So if a patient needs that, to happen for them in the next hour, that's not going to do anything. Or at least if even in the next, 2 or 3 days, their blood level is not going to come up. However, we don't want it to become too elevated. And the reason being is it can cause a patient to have clots. So, or increase their risk of having cardiovascular, problems like a heart attack or a stroke when the level becomes too high. So what blood test would we measure to monitor that process?
Hematocrit, your H&H.
So hemoglobin and hematocrit, but more specifically the hemoglobin. And so if it's above 12, then we have given that patient has way too much. Okay, and this is what your end-stage renal disease people. That's way too much. But it's not going to work quick. And you may.
Yes,
okay, go ahead.
Yeah, why are you giving this erythropoietin? That's for again?
This is for your end-stage renal disease. Sometimes they lose blood. So, they'll give them, as they're doing all those fluid shifts from dialysis and all of that, to try to get their blood levels up. They maybe put them on or give them Epigen during dialysis or put them on Procrit afterwards. So we just need to monitor that.
Ms. Hudson, I have a question.
Mm-hmm.
Is it about 12 or 14 on a hemoglobin? I know it's on like the higher side of the normal range, but isn't that still a good range?
Although it's a good range, it's too high for them.
Like just because of the viscosity of it or how thick it is?
Mm-hmm.
Okay.
And we're looking at the patient's blood, not the medicine.
Right.
It's not the medicine. But it is at the higher end of normal. But just, for certain groups of folks or conditions or of people, even though it's within normal range, it may be too high for them.
Hemoglobin, that's 12 to 18, right?
It depends on whether you're man or woman.
I know women 12 to 6 to 6. I know it's 12 to 18 for both of us. I just know men and women 12 to 18.
Right. But I don't think it's that one for women. Hold on, let me look real quick.
Women is 12 to 16 also. Then men 14 to 18. I don't know.
For men 13 to 17, for women 12 to 15 or 12 to 16. So, but either way for them it's too high.
Okay.
It's just like with your when we get to perfusion, we're going to talk about how women present differently for a cardiac arrest compared to that of a male, and how your diabetic patients present differently, compared to that of women and men. So just understand that even though that's normal range for these sets of folks or for end-stage renal disease people, that would not be an acceptable range. So they're kind of an exception to the rule.
So for this whole process, all of the work for those, what medications are we to remember for the exams?
The ones we've already talked about?
Yes, can we just remind ourselves?
I've already sent it to you.
Yeah,
we talked about the declomycin, we talked about K-Exalate, we talked about mag sulfate. I mean, all the ones that we talked about.
The third one, you saw K, what do you call it again?
The K-Exalate we talked about with the potassium.
Okay, K-Exalate, okay.
Yeah, when your potassium level is too high. And that's the one that they poop out, but we need to make sure they have good bowel sounds before we give it.
Okay.
Because otherwise, if their bowels aren't moving, then, bowel necrosis can occur.
That
Don't you do the
K-Exolate,
DABP as well? That's vasopressin.
Yep, the vasopressin for DI.
Yeah, that's DABP.
But I sent you, you should have a list already for all of your fluid and electrolytes with the medications. Because I sent that to your group and to the class. So you should have it.
Okay, I'll check it.
So remember, the DDAVP, which was the desmopressin that we talked about last week.
I have a question, Ms. Hudson.
Uh-huh.
On the K-Exolate, I know that's a helpful medication for end-stage renal patients because their kidneys can't excrete it. But would K-Exolate also be used in a patient who does not have kidney failure?
Absolutely. It's not just specific to them.
Okay.
It's used based on how it works. But it doesn't matter whether they're end stage or not. You can give it to any patient if they have hyperkalemia. So it's designed to treat the electrolyte imbalance, and it's very good at what it does.
I just wasn't sure if that was the top choice of medication over a potassium wasting diuretic.
It depends on physician, but overall, if someone has hyperkalemia, they're going to start that dextrose, the K-Exolate, and the insulin to help shift it out of the blood.
Okay.
So that's its whole design.
Okay.
So I've had patients that were not in stage renal disease that was getting that triplicate medication or that treatment modality to help decrease potassium levels.
Okay. Oh. K-Exolate, dextrana, and insulin. That's what you said, right?
Yeah, K-Exolate for hyperkalemia. So that's when your potassium levels is greater than 6 or 7 or whatever. It's over the normal. So then that, once you start getting at 7, if you're alive, praise God.
Okay, so dextran lowers kalemia?
I'm sorry?
You said that you gave 3 drugs now: K-Exolate, dextran, and insulin. Or what I thought? What was the second one you said?
It was K-Exolate and some type of dextrose,
Okay.
some type of sugar. It may be 50. It's all doctor dependent, but some kind of dextrose preparation and A&D insulin.
Okay.
So it's designed to help shift the potassium out of the blood.
So which would be the very first medication you would give? The insulin to put the potassium back in?
It's not, they give them all. I don't believe this one must be done first, second, or third. Unlike if you were trying to increase the potassium, and if your magnesium levels were low, then you would give
magnesium first.
You would give the magnesium first in order to increase the potassium.
Okay.
Okay.
Mm-hmm.
So those are good questions.
Okay. Really, why don't we give potassium IV push?
Are you kidding me?
Why do we not give it?
No. That's what they give people for lethal injection. Why would we give that?
No, yes, I just want to know just the whole rationale. I know it's
number one, it burns going through, so you have to be worrying about the damage to the vessel. Number two, you have no control over giving it IV push. So if you push it really quickly, you have a whole heap of potassium hitting the heart at the same time. Okay. So that's totally inappropriate. It's the reason why we only give, the max you can give is 20 milliequivalents per hour. It's preferable to do 10 milliequivalents. And even at 10 milliequivalents, and even if it's diluted in 500 milliliters of solution, the patient still complains of they complain of burning at the site or, in the vein. So it's very damaging and harsh on your vein. So you definitely don't want to push it. Have I seen people push it? Yes, I have. Have I seen patients going to VTAC because of it? Yes, I have. So, that's the reason why it used to be in a bottle very similar to the multi-dose saline vial, which is like a 30 milliliter bottle with a green cap, right? This one was the same 30 milliliter vial, but it had a red cap. But if you turned them and someone had already popped the caps off of them, they were the exact same bottle. So that meant you had to READ, you had to read the label in order to determine if you had potassium or normal saline. So that's why they took them out of the units. And then now if you want potassium or need potassium, you got to go through the pharmacy. And it was definitely a safe move because it was easy to make the mistake. But yes, lethal injection, you know, you ever see Law Abiding Citizen? It gives you a good bird's eye view as to the medicines that they deliver for lethal injection. But it is
okay. So how is it given? How is it given?
Potassium? You're going to give it in a 500 milliliter bag or maybe a 250 milliliter bag of saline.
Okay.
So yeah, you don't give that flush. You give it as like an IV piggyback or an IV infusion. Hopefully, if they had a central line, that would be great. But once if you were to inject it, you can't uninject it. Does that make sense? So if you push it in, it's not like you can withdraw it back out and it's going to come right back out. It doesn't work like that. That'd be nice, but that's not how things are done. That's the one thing about giving anything IV push. Once it's in, it's in. So now you're on a waiting game. Okie doke.
Yes, ma'am.
All right. Well, it's 6:15. And so I don't have any psych stuff for you. I'm sorry. But I know medicines and I know when to give them and how they work. I would definitely know that because, you know, that's a good portion of how you manage your patients that have, you know, those types of disease conditions. You know, things like your, what is that? What do they give for dementia? Did she cover dementia?
Yes, she did.
Yeah, what did they give for dementia? They used to give, it's Aricept. It's Aricept. It's the other name for Aricept. I'm trying to think. Give me a sec. Donepezil. That's what it is. So Donepezil, the stuff that they give for, you know, when should you give it? Who should give it for patients that have dementia?
How do you spell that?
Aricept is Aricept. Donepezil, which is the generic, like Done, Done, Pezil. So didn't you all cover that yet on Tuesday?
Yes, we did, but not our time. I guess.
Oh, gotcha.
Yeah.
Got it. So, you know, yeah. Any other questions? Can't hear any of that. Was that it? Because it sounded like there was a question.
I have a question, but I can't remember the concept. So,
Okay.
For the concept for this coming week, let me see if I can find it.
Wow.
The lifespan responses, I couldn't really find stuff on that. Is there something specific we should search for?
I didn't get that. I'm so sorry.
On the lifespan responses for stress, is Is that just like intervention
Okay.
throughout the lifespan?
So basically, you know, how would you tell people to minimize stress? What would be the goals that you could teach them to do?
Okay.
You know, what types of people have high stress levels? Your type A personality, your O type blood. I mean, those are usually people that have high stress levels. So I would be looking at how to, you know, how to help them minimize that, whether, you know, I call it yoga meditation breathing, so they could do that. You know, not working as much. That'd be another thing to do. Take breaks. You can't work 90 hours in a day. There's only 24, and you can't work all of those. So they would need de-stressing strategies, and then being able to identify stresses in their life, and then take vacations. Europeans take 3 months off a year. How is it that they do it and still flourish and have businesses and everything, and we're working all year round in America? How is that possible? And then in the middle of the day, they siesta in the middle of the day for 2-3 hours. But we literally work from sunrise to sunset. So just, you know, all of those things play a role, but you have to know or be able to identify when you are under stress. If you're agitated easily, your concentration level, you know, quick to anger, maybe you're having anxiety, difficulty sleeping at night. So those will be all signs and symptoms of stress, and which is basically insomnia. Does that make sense?
Yeah.
Okay. Well, it's 6. Oh, yes, sir.
No, I was like, yeah.
Oh, he's like, I'm out. All right, so 6:20. So give this time to load, and then I'll go ahead and add it to the YouTube channel. So it's DCCD, and then it's just a space, and then J2. It's not case sensitive, so you can type it in lowercase and still get to the same place. If you missed any of the beginning, that's what you'll be able to find it there. All right.
Thank you, ma'am.
Thank you, Mr. Sun.
You're welcome. Enjoy your day.
You too.
Okay. Bye-bye.
Goodbye.
Bye-bye.